You're listening to RideAlong, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the RideAlong. Welcome, everybody.
Welcome
to the RideAlong EMT School Podcast. We have a very, very special episode for you today. One of the ones that we love doing the most, and that is an interview with somebody in the EMS space. I had the absolute pleasure of getting to meet a great company at EMS World Expo just a few weeks ago. Their name is Compression Works. I got to meet the inventor of a super cool tool, and that is the AAJT-S, which is it stands for the Abdominal, Aortic, Junctional Tourniquet Secured, right? Did I get that right?
Stabilized.
Sorry. And I looked at this thing, was like, that's super cool. I've never seen that before. And then I got to meet Dr. John Croushorn, who's joining us today on the podcast. Thank you, sir, for coming along.
Yeah, I'm glad to be here.
Yeah. So if anybody's interested, I have, there's a video in the RideAlong Instagram where Dr. John is walking me through how to apply the AAJT-S, which was actually got a bunch of views on it and
awesome.
Was a lot of fun to do. We had the whole Compression Works team there. They're like, holding cameras, I'm like, wow, this has turned into a production, and it came out really good. But yeah, thank you for joining us, and it's great to have you here.
Yeah, thank you.
Yeah, thanks. I'm glad to be here.
So, Dr. John, did I miss anything on the AAJT-S? Like, what is it?
Well, it's a device meant to control bleeding primarily, and the idea of controlling bleeding is providing proximal control. So the idea, if you have bleeding at a site, you need to be able to push in on the vessels and stop the blood flow through vessels just to control the bleeding. Yeah. So it works differently than an extremity tourniquet, but it has a wedge-shaped bladder underneath the base plate. It straps around the body at 3 different locations, and then once the wedge shape is inflated, it pushes into the body cavity and just stops all the blood flow. It's like a faucet. You just turn the faucet off.
Yeah.
Okay.
It's actually, it's the coolest wrestling belt I've ever seen. It's shaped like I swear I had like the WCW belt when I was a kid that had the cool metal plate on it. And when I saw it, and now I understand why at the booth you guys had a wrestling belt. I'm like, oh man, funny. It's kind of like it's pretty cool. And really, I think the most interesting thing that I found about it being new to emergency medicine was, like, I'm very familiar with limb tourniquets. We use those a bunch. We learned, like, day one in EMT school, they handed us limb tourniquets. They're like, all right, time to practice, which is great because I have some background in tactical medicine and really important skill to use. And then when I saw this, I'm like, oh, that is interesting. That is because it cuts off, like, or it occludes everything in the aorta. And I was like, aortic tourniquet. That's like the main vessel running through the body. Of course, with my newfound EMT knowledge, I'm like, that's pretty big. Like, that's the biggest one. It's like the OG of vessels, right? So I'm like, where does that go? So seeing the demonstration and like, oh, so you don't even have to like get into the inguinal space, like the kind of traditional junctional tourniquets where it goes into the hip and like gets in those really difficult spots. It's like, no, we're going to cut it off before it even gets down. Right. So that was, I thought, super interesting. I'm like, that's a story that needs to be told. Something that I hadn't seen before. And being new to this, I haven't seen much. But, being able to see that and go, well, that's unique. But why don't we start with hearing a little bit about you? Where did your journey in medicine start, and where are you working now?
I live in Birmingham, Alabama, and my background is as an emergency medicine physician, and so I still practice emergency medicine in Birmingham, but I was finishing my emergency medicine training when the towers fell, and so I
in
decided to join up the
2001?
military. Yeah. I was finishing up my ER training in Jackson, Mississippi. The towers fell, and just felt compelled to serve. So I joined the Mississippi National Guard at the time, and our unit went to Iraq in 2004. Combat aviation unit. We didn't have any medical helicopters per se, but we did do some medical, what they call casualty evacuation, since we didn't have a medical platform. But and then after working in the combat aviation area for quite some time, I switched over to special operations, and the idea of requirement-driven development was something I was introduced to. I was very interested in hemorrhage control before that point, but became involved actively in researching ways to stop bleeding then. And we had a guy who was killed in 2005 from pelvic wounds, and he had great care. He was pulled from the breach point where he was wounded, and 4 minutes after the point of wounding, he was put on a helicopter and flown to an awaiting surgical team. He was alive when he arrived, but they could not stop the bleeding fast enough to save his life, and so he died from those wounds. And the idea of requirements-driven development would be when you return from a deployment, you come up with sort of that after action review where you're reviewing what you've done and what you could have improved upon. And so deciding, hey, look, if we could have done this, we could have done our mission better, faster. Maybe this person would have lived. And so we would look in the medical market space and say, look, has anybody done this? And for this one, it was, has anybody created something that would stop bleeding, going all the blood flow down to the pelvis? We could have maybe saved him. And we didn't find anything. If we found something that came close, we could go to the company and say, hey, we'll help fund you to change this a little bit just for our purposes. And then when nothing existed, we would try to come up with solutions. And so we actually turned the history books open and looked at a solution that had been created back in the 1700s by a guy named Lister, who had authored most or many modern surgical techniques. He created an aortic tourniquet that looked like a big C-clamp, and and you would anchor it in the lower back, and then it would have this big knob you'd turn down, and it would push into the mid-abdomen and stop blood flow through the aorta. And in the late 1700s, he said, the only place you'll find this is in museums. We'll never use them again. The reason being they had optimized the surgical technique of opening the abdomen and just cross-clamping the aorta.
Right. So that...
And so...
In traditional, because I'm wrapping my head around like what options existed beforehand, right? So, like you're in the military, like traditionally, if somebody comes in with a wound that's bleeding, that's so far in there, like the option at the time would be like a clamshell thoracotomy, right? And then having to get in and like cross clamp the aorta from the inside, right?
Generally, yeah. If they were going to, if they arrived at a medical treatment facility, the problem is a lot of these people die before they even get to the hospital or a medical treatment facility or a battalion aid station. So we were interested in what could the medic do at the point of injury, and we had been teaching them to put a knee into the mid abdomen, right around the belly button.
Right. Okay.
And so if you could put pressure there, you could sort of stem the flow of blood. That was the thought. And
but that's hard to
definitely work.
You can't keep that. Like if you need to move a patient, it's you can't keep a knee pressure into the abdomen the entire time. Especially, I would imagine it's difficult on like a helicopter, and moving and
the consistency of that application.
My co-inventor was the chair of the Department of Emergency Medicine at Medical College of Georgia, and I had a faculty appointment there. That just from the research standpoint, and in 2006, all all ER residents that need to graduate and become ER doctors have to come up with a scholarly project. So they're always looking for a project. And we said, you ought to look and see if this practice of putting a knee into the mid-abdomen works. And so they designed a research study using a dumbbell or set of dumbbells to see how much weight over the belly button does it take to actually stop all the blood flow through the aorta. And they found that somewhere between 100 and 140 pounds reliably stops all the blood flow through the aorta. And they wrote it up. They presented it at a conference in New Orleans in 2006. And we went to dinner with them and we're like, hey, we know some people that'd be very interested if you came up with a device that did what your research shows. And these guys were like, no, we don't want to do any more research. We want to go out and make money. Okay.
That's the American way right there.
Yeah, my co-inventor and I literally over dinner sat down and sort of sketched a few things out. Like, I think we could probably do this, don't you? And we came up with a few ideas. And by February in 2007, we started messing around with prototypes to see what would work.
What were the original prototypes like?
Oh, well, it's sort of funny. I mean, I think the first time we got a sense that we might be onto something, it was a rolled up blood pressure cuff under a textbook with a tight belt wrapped around the abdomen and pump it up. It didn't fully stop all the blood flow, but it did sort of stem the flow. I sort of tried to further that by sewing sort of a wedge shaped canvas thing. And I needed some kind of an inner tube to put in it. So I went to like a local bike store and I'm looking at these tires and the guy came by and he said, can I help you find something? I said, yeah, I need the smallest, fattest tire inner tube that you have. And he looked at me, he's like, for what? And I said, it's not for a bike. I said, and I sort of described to him what I was trying to do. And this is back in 2007. And he helped me find one. And interestingly, fast forward to like, probably 2013, 2014-ish, I was at a military medical conference, and this Special Forces Green Beret medic come up to me, and he said, hey, sir, can I ask you a question? I said, sure. And he goes, you invented this thing, right? And I said, yes, sir. And he said, do you live in Birmingham? And I said, I do. He said, you didn't happen to come into a bike store and ask for a real fat, small tire, did you? And I was like, yeah. I said, he was the guy that sold it to me.
Oh,
and
wow.
Then he was working there sort of part-time, and then he decided to join the military, became a Green Beret. He goes, I was over in Afghanistan. I had your device, and I just got to thinking, I wonder if this is the same guy, because I had explained to him sort of what I was trying to accomplish.
Are you serious?
Yeah. It was a fun sort of reconnection to the early prototype of the device.
What a crazy reconnection.
Yeah,
It's like coming completely full circle. Like, oh yeah, I need this bike tire for this medical device that is for this very specific thing in like a special operations context. He's like, oh well, in 5 years or however long it's going to be, when I'm that guy that's using that thing, I'm just going to come like, hey, it's that thing again. Yeah. Like that is like crazy.
It's a small
connection.
world.
Yeah.
So, Dr. John, in regards to development, you were talking about the history of abdominal tourniquets all the way back, in history. And what was the impetus for utilizing more of a pneumatic device versus a mechanical device, putting pressure in that area?
Yeah, no, it's a great question. In fact, there is a mechanical device. When in 2007 in February, we did 2 provisional patents. One was for a mechanical device, a sort of a C-clamp-like device, and then another one was for the pneumatic. And what we found is with the C-clamp type device, as you screw the device down, the focal point that wants to tilt is the point in which the screw is attached to the device. In other words, the deeper that goes, the further it gets away from the body. And it just sort of wants to tilt one way or the other. And so it's very hard to stabilize. There's a product that was actually first to market called the Combat Ready Clamp, invented by a very good friend of mine.
Okay.
And he stabilized it better than I had in my provisional patent work. But it was pretty large. It's a little heavy, pretty bulky. It definitely works in the inguinal region. They were hoping it would also work for upper junctional bleeding, and it had been applied a number of times, but unfortunately didn't work very well in upper junctional bleeding. But ultimately it had to do with stabilization. So the idea that in this one, the AAJT-S for stabilize, every change we've made to the device has been to try to make it more stable. So the original device, instead of having that WWE belt shape, that whole cummerbund shape around, had 3 sort of solid pieces, a base plate, and then 2 sort of wing components. And then we found that when we joined those all together in a piece of low density polyethylene, it prevented the torque from happening. There's a little piece of shock cord to keep the wedge apex at the midline. So as you inflate it, it just goes straight out, because if you have a wedge that's laid down on its side, as it inflates, it wants to sort of tilt the whole device
Right,
up.
it'll try to go like the path of least resistance.
Yeah, and then we originally had a windlass device, and on the top to tighten it. The ratchet allows you more tightening. So, everything that we had a thinner belt, we went to a wider belt that went around the body. So everything has been to try to make it more stable, because as you inflate it, as that base plate gets off the body, it wants to sort of tilt too.
So the wider it is, the more stable it becomes.
You sort of notice it when you put it on. If you put it just on a dummy mannequin that's fairly rigid over the abdomen, it will actually rise up, and it might want to tilt a little bit. When you put that over a person, their belly is actually soft, especially those that are unconscious. They can't tense their abdomen.
Sure.
And it doesn't really rise up off the body. The pressure just goes down into the body. So that's the idea of the mechanical versus pneumatic reasoning for us going that way.
Interesting.
Yeah, makes total sense.
See, now I have a question based off of your original prototype, though. What book provides the best stabilization?
You're funny. The idea was, we knew that if you were going to try to use some form of an inflation, a bladder or an inner tube or whatever you were going to use, you needed all of that inflation and displacement to go toward the body.
Exactly.
So you just need something rigid. I can't remember what textbook we used. I think it was pretty thick, but the idea of just simply putting that around the body and then a tight belt so it would not rise, and then allows you to whatever displacement you get from inflating that blood pressure cuff to go down. But
I would imagine
that was just sort of to see if we can affect anything this way. And ultimately, having a device that had a wedge-shaped bladder was what ended up working the best.
So it would be so fitting if it was like, we used War and Peace, or like something big. I mean, I'm pretty sure my EMT textbook would work pretty well for a stabilization. Like it's like a phone book.
Yeah.
But that's so, I love hearing the story of how the things evolve. Like, oh, well, we had this idea. If we have it, extend out the bottom of a solid device, we strap the device around, and then hearing like, what can we use in our environment to approximate the end result? Like, we know it's not going to be a book, but for right now, we have a book, and we can approximate.
And you got a knee.
Yeah.
You can
how do we make a
knee
knee
to somebody pretty quickly? And but you were sort of alluding to this earlier. If you're having to transport somebody, you can't really keep a knee on them the whole time.
Yeah.
And these patients bleed so quickly. And so just being able to put something on quickly. In fact, you can put it over the inguinal region. It works very, very well if you have an isolated one-sided junctional injury. You can leave it on longer than you can at the abdominal site. So it's a safer sort of application. But generally, if you're going to put an extremity tourniquet on the leg, we usually teach 2 tourniquets. Most adult males require 2 extremity tourniquets to stop the flow of blood, arterial blood through the upper leg. But you can put this thing on faster than you can 2 extremity tourniquets.
Okay.
And so if you have bilateral amputations, which unfortunately happened with IED type injuries, and then with the Ukraine conflict with the drone injuries, it's a very common.
I can imagine.
So Yeah, and artillery and the drone injuries are just horrendous. But so it much faster that you could for extremity tourniquets. You just throw this over the mid abdomen and inflate it in less than 60 seconds, and you have that full hemorrhage control.
That's interesting. Yeah, because I would imagine. I mean, if you're having that much trauma to one leg, it's likely going to be afflicting both, and bilaterally, and having that solution that can cover both at the same time is always going to be faster than, all right, let's tack the problem on both sides. Because really, if I'm hearing it correctly, if you're getting bilateral injuries, it's really 4 tourniquets that you would have to put on versus 1.
Yeah, and those kind of injuries fortunately don't happen that very often.
Sure, but in a worst
side.
Case scenario.
Yeah, well, and then again, the original injury that we were really trying to treat, the idea of pelvic wounds, because the pelvis, the lower abdomen and pelvis are almost always below the level of body armor.
Mm-hmm.
They do make some. When I deployed Iraq, they gave us these. They called them groin protectors, but when they hung off the bottom of your chest rig, they really only sort of covered the lower abdomen, maybe a little bit down into the pelvis area. But so anyway, if you have injuries in the pelvis, and so from the civilian standpoint, most of the EMS usage has been from pelvic bleeding type injuries.
Mm-hmm.
So sometimes that's from blunt trauma, a car accident, and sometimes penetrating trauma, somebody getting shot below the waist. And this just gives a solution to be able to stop bleeding in that situation.
Gotcha. So let me ask you a question. This is such a fascinating story. Okay, so you join the military, you're seeing this traumatic injuries, combat related injuries. You see you identify a problem. Hey, we're seeing these types of injuries. Maybe something can exist for that. Is this the only thing that you've ever identified and been like, oh, I'm going to invent something that, and let's just let's develop it out of thin air. Let's do some research. Let's find this medieval C-clamp device. Have there been other things? Is this, or is inventing your side hobby?
Well, I do enjoy innovation. I think it's very motivating. It's very fun to be involved with. Mm-hmm. And this has taken pretty much the entirety of my attention since 2005-ish, 2006-ish. But I think that in my mind, everybody is an innovator. I mean, you're around problems, you come up with little solutions, or you see the solution that you're using is not perfect or could be improved upon. And so there are some other aspects of innovation I've been involved with. The focus point for development in the special operations unit that I was privileged to work with had also body armor things and other hemorrhage control products and ideas. I've done research on some of the hemostatic agents, not coming up with any new ones. I think we've got some tremendous options out there. We got a lot of options now.
Yeah.
Back in 2004, there were very good options available that are still available now, but now we have just so many you can, pick from a variety of ways of trying to stop bleeding. But I think the idea of research and trying to see is there a better way of doing something, or how good does this actually work, was something I had not really thought about getting into when I became a doctor. The idea of doing research wasn't necessarily that appealing to me until I began to understand that, hey, if we make progress, then people that I actually really care about might not die. Mm-hmm. And so that's a very motivating principle, I think, to sort of live life by. And so that this requirements-driven development had been motivating from a standpoint of keeping my brothers safe. Now my son and son-in-law, both Marines, the idea of trying to keep them safe sort of continues the drive from the standpoint of hemorrhage control and innovating this specific product. But then as we've gone through this one, it's been interesting because it started with penetrating trauma and military trauma. but it's ended up blossoming out, and we find a lot of different things that specific device, our device, is useful in. And so that's become really fun. I think the idea of having come up with an idea that ultimately has been effective at saving life, now it's very motivating. You met our team. We get charged up every week. We hear of a couple of 2-3 lives saved each week, and it's just fun. It's at this point, it's just really fun hearing about, oh, you used it for that. Oh, okay. All right.
Yeah, they're fun. They were super excited about everything. And I was like, that was my highlight, like one of the highlights of the week being there, just the energy that was coming from the Compression Works booth. I'm like, this is the place to be. Like, these guys are the ones I want to hang out with.
That's so funny.
Yeah. Because, you go to some booths and it's just like, you'll see somebody like on their phone at their table. I know this is kind of getting outside the scope of the interview, but like, I'm sure you've been to some of these conferences or expos where it's like, you'll have some teams that are just super engaged. They're really excited about the product that they're talking about because it's something that really like it's making a difference. And then you got some booths that are just like, it's one of a million. And like, they're sitting there and they're like, oh, hey, did you want to hear about our product? No, it's okay. I have an appointment. I gotta go. Like, it's just, but like the Compression Works booth was like, oh, these guys are fun. Like, I had so much, they were good people. But, question for you. Cause like, I see a theme here in kind of like the progression from like military to civilian world. And, it's funny because I'm making this link in my head because obviously I'm going through EMT school right now. So much of the EMS, like, the things that we learn to do in EMS have a impetus from the military space, right? Even the idea of EMS in general comes from, battlefield medicine.
Sure.
And like, do you find that story, that progression from like the battlefield space to the civilian space, the kind of emergency medicine side for both you and the AAJT-S, has that been a similar transition?
Well, yeah, it's a great question. I think that in almost all of the times where we've gone to war, there've been innovations that occur that end up coming back to benefit the people at home eventually. So, the idea that in World War II, starting to use plasma on the battlefield, we found, oh gosh, that actually works a lot better to keep people alive, to get them to the hospital better than the IV fluids. And then, in the military, giving blood. And now we have a lot of EMS organizations throughout the country that are now using blood before someone even reaches the hospital. And it's keeping people alive, giving them a chance to live. So there are all these different little technologies, extremity tourniquets. When I started as an emergency medicine doctor, most EMS wouldn't use an extremity tourniquet. They were afraid they would get yelled at getting to the hospital, and there's an extremity tourniquet. What do you put that on there for?
You're going to lose the limb. You can't.
Well, it used to be this thought that it was the last resort thing to do.
Right.
And now we actually teach it as not the last resort, but the very first thing. You only use pressure long enough to get the tourniquet out.
Yep.
And because you can always convert the tourniquet, and there's a lot of emphasis on once you've applied the tourniquet, dress the wound, let the pressure out of the tourniquet. If the dressing that you did, or whether it's packing or just a tight pressure dressing, if it works, then leave the tourniquet in place without pressure. So this is a sort of a continuation in that, because it definitely began that transition as a hemorrhage control product from military to civilian space. But the problem set that the civilian medic has is generally different in many ways than the military problem set. So instead of a lot of ballistic threats, little fast pieces of metal and stone flying through the air, they're dealing with a lot of blunt trauma.
Right.
And so the ability for the device to control the blood flow through the aorta has applications, whether it's penetrating or blunt. And so the idea, what we really were able to accomplish by learning from the military experience was the safety side of it. So, hey, at the inguinal and the axillary place, it works quite well. It's safe up to 4 hours. At the abdominal site, it's safe up to 2 hours. Most civilian trauma is within 2 hours of a hospital. Mm-hmm. You can get to places that are more remote, that do have long transport times, but you sort of have to work to get there. And for those that are more remote, they very rarely will survive to a hospital. This allows for most of those the option, at least, to survive to get to a trauma center to be able to be cared for.
Sure.
Yeah. So in the development of it, like the first places where you started kind of bringing it to bear, was it in the military space? Like so were there different challenges or like hurdles that you had to confront in like changing minds in the combat space, like the military space versus the civilian space?
Yeah. So I think that there was less mind changing type things in the military space than the civilian space, from the standpoint of the military knew that they saw the problem. These guys were getting injuries that they could not treat. So these junctional wounds, they put tourniquets up as high as they could. You can put pressure over that junctional space. You can even, the Special Forces Medic course teaches how to use a Nalgene bottle to apply over a groin space. And sort of the joke in the Green Beret community is that they buy Nalgene bottles for the course, but they don't carry Nalgene bottles, so they don't use them in the field. But they have the products. So they have junctional tourniquets they can use. When you faced with a casualty that dies from bleeding, it's you just feel like you should have been able to stop the bleeding.
Yeah.
And so from an extremity tourniquet standpoint, they're wonderful because they've saved so many lives. The junctional space, when we had so by 2012, we had some junctional tourniquets out there, but very few were available to the medics at the point of injury. Like the military said, yeah, these work. But then they didn't really follow on by saying, we need to get them out there and field them.
Right.
And put them in all of the kits. So that's something that's changed quite dramatically since those early days. There's more availability. And from the military standpoint, it's not that difficult for the folks at the top to say, hey, this works. Let's push this out. In the civilian space, there's not like a U.S. Surgeon General over EMS, who can just say, okay, all EMS start using this. You go to it's individual medical directors, individual states. Some states, like my state in Alabama, has a central approval authority. So a physician or a collection of physicians, as it were, decides sort of what is appropriate for use in the pre-hospital space in our state.
Right.
And so we went through that process in 2016, and they felt, this is a safe product, and we got it out and began to see life saves almost immediately. So but in the civilian space, you almost have to explain what the problem is, because you're not replacing something that they have. You're not just sort of improving upon something you have. You're talking about a capability that they didn't know that they didn't have.
Right.
Hey, what do you do for pelvic bleeding? Well, a lot of guys say, well, I put a pelvic binder on.
Right.
Well, for pelvic fracture stabilization, the pelvic binder helps. When we think about somebody who's bleeding from a pelvic fracture, 85% of those are bleeding from venous injuries to the pelvis region. About 15% are osseous or arterial. But the whole concept of using the pelvic binder to stop that is that you take an open butt fracture, you close it or make it in the regular shape of the pelvis, but then you allow bleeding into that space until there's so much blood that the pressure from the blood stops the further blood flow, which is a little crazy. You're just going to let it bleed? We're just all of that blood. Well, that's a lot of blood.
It is a lot of blood.
Yeah.
So when you so like ours goes above the pelvis generally when we're trying to stop blood flow to the pelvis, but I think Miami-Dade Fire Rescue's first life save was a parachutist that had burned in. Her chute didn't open.
Oh.
And she hit the ground hard. She did not hit her head. She didn't lose consciousness during it, but broke her pelvis horribly and her back. They got there and they were using the device because the device is an approved pelvic stabilizer. So they put it around the trocaners and tightened it up. You don't have to inflate it when it's just a pelvic stabilizer. So they did that, and so it closed the pelvis. But she became hypotensive, like she's bleeding.
Yeah.
And every paramedic can tell who's got a pelvic fracture. But no one can tell who's bleeding from it until they start showing signs of shock. And if you have one drop in your systolic blood pressure to 90 en route to the hospital, their chances of dying go up threefold. It triples their mortality. So when the paramedic saw that her pressure started dropping, he, instead of moving it up to the abdomen, he kept it at the pelvic side and he inflated it there. So now that potential space that you bleed in, you got the bladder, it's pressed in. And the bladder actually does push on the veins inside, or the arteries inside the pelvis. So you do stop arterial flow.
Sure, yeah.
But you also stop the venous flow by completely putting that pressure in. So she made it to Ryder Trauma Center at Jackson South in Miami. And the trauma surgeon called me right after he used it. And he said, "You got to tell me what this is." He goes, "This saved her life." And Dr. Enrique Ginsburg, he's a very, very well-known trauma physician worldwide, really, but he's in Miami he's amazing. And they would actually do a surgical technique called RIBOA, which is resuscitative endothelial balloon occlusion of the aorta. Basically, the trauma surgeon starts a catheter like a heart surgeon does in the femoral artery, and then they push a small little balloon up into the aorta, right around the belly button, right? It's the same sort of location that our bladder is focused at the abdominal site. And then they blow up the balloon. It stops all the blood flow to the aorta. And he said, "Listen, that takes us some time to do. In a perfect scenario, maybe 8 minutes, but that's 8 minutes of bleeding." And so this device went around very easy, but basically allowed the same capability as RIBOA,
right,
to be done by the paramedic in less than a minute.
Yeah.
And so the U.S. military in 2017 actually did two studies, the Institute for Surgical Research and the U.S. Air Force 59th Med Wing, both in San Antonio, looking to said they also, independent of us, we didn't even know they were doing this study. They said this looks like Zone 3 RIBOA, blowing this balloon up at the lowest portion of the aorta right before it splits to go down into the pelvis. And both of them found like, yes, this is equivalent. In fact, actually, it works a little better than RIBOA because not only does it stop blood flow through the aorta, it stops blood flow through the IVC, the inferior vena cava, the largest vessel coming out of the heart.
Right.
So most of our blood vessels have valves in them.
Yep.
You can see that in your arms and your legs. There's no valves in the IVC. So if you stop all the blood flow through the aorta, you still get blood flow out the bottom of the heart. And so this sort of cross clamps everything. It just stops all that.
Yeah. Just shuts it all off.
It shuts it all off.
We'll just cover it from they'll just squeeze everything.
Then it also allows you the ability. So if you do sort of cross clamp the body like that and you stop all the blood flow, now any intervention you give, be it fluid, blood, medicine, you get it to the parts that matter. You get it to the kidneys, the liver, the spleen, the heart, the lungs, the brain. And so those interventions have a more direct impact in the parts of the body that need to be alive and healthy by the time you reach the hospital. So
this was actually one of the most fascinating things that you had mentioned when I talked to you at the expo, because the hot topic of EMS is obviously like blood product, right? Like carrying blood product in the field. And can you tell me about because I think this is very related, right? Like the combination of both an aortic tourniquet and blood product together. Like what are the potential benefits there?
Yeah, well, you're right. The hot topic in EMS is getting the blood before they get to the hospital. And the U.S. military's experience in Iraq and Afghanistan extended to massive blood transfusions. We had guys and girls that got over 170 units of blood and lived, but that's losing all of that amount of blood out of your body system because you got so many holes or injuries to the inside. And so as we move forward, when the U.S. military now is preparing for large-scale combat operations, the concern is that we're not going to have enough blood to go around. And so we don't know if somebody requires a small amount of blood, maybe more than 4 units of blood, we might not have enough to try to save them. They may not live. And so part of the thought process is, well, how can we improve that? We either have to find a way of increasing the blood supply. And so there actually are some techniques to be able to use non-O negative blood. O negative blood is the universal donor blood.
Yep.
So most of the pre-hospital space blood supply right now is O negative blood. Well, it turns out that might not be the only option. And so the U.S. military is looking at that, but that still doesn't greatly improve the amount of blood that you have access to.
Sure.
The idea about using the device with blood is that if you cross-clamp the body, could you get more resuscitative benefit with 1 unit of blood than you could with 3 or 4 units of blood? And so the first sort of hint at this we had is, I put it on a guy who was shot in the femoral artery. It had a transected deep femoral artery in 2013. And we actually resuscitated him with about 3 units of O negative blood, and he made it to surgery. I think got another unit of blood in the surgery, but the hospital sort of looked at the case and said, normally we resuscitate that kind of injury where somebody was in a severe state of shock when we started with quite a lot of blood. And part of that's because until they get to surgery, we really don't have a way to fully stop that bleeding that they were experiencing. It was a high inguinal injury. And so each unit of O negative blood costs more than the one of those devices. And so the hospital's like, look, this makes all sense in the world to us. If it saves us even 1 unit of blood transfused, it's worth its weight in how much it costs. But right now we have a couple of research projects that are in the works that the U.S. military is funding, looking at this specifically. How much blood could we, how much resuscitative effect benefit is it when we apply this device? So the Swedes did a study looking at resuscitative benefit of applying this device versus Roboa.
Mm-hmm.
They were just using saline. It was a pig model. We don't use crystalloids in resuscitating trauma patients, but it was mainly looking at, is there an economy of use argument for the device? And they found that they could keep a animal with a femoral injury resuscitated with this device versus a Roboa device with 7.2 times less amount of fluid. It was a dramatic sort of finding or statement that they made. Again, it doesn't have it's not a direct, you can use 7.2 times less blood in somebody, you'll get that much more benefit from the device, but you do get a benefit. And so I think a lot of folks see sort of a common, the reason we do research is that common sense isn't always right.
Right.
So from a common sense perspective, it seems like, yeah, that'd be right. You put the device on, you can resuscitate people less blood. The big advantage in the EMS community, reason there's a lot of excitement, in fact, the Spark Academy is probably one of the best known resources training EMS providers on how to do blood programs. I mean, everything from how to set it up, what equipment do you need, and how do you train people to administer it. And they use our device in a lot of their training. The Ukrainians have a blood transfusion set that they package all of the things needed to both do a walking donor, so using a soldier's blood to if they can match them with the injured patient. But they put one of our devices in each transfusion set because they've seen, then they don't have a lot of hard data. They're not doing, hey, let's do some patients without it and some patients with it.
Yeah, they're not doing the double
there's
blind.
There's a benefit. Yeah. We're using it, and so we're not going to let somebody suffer and not use it. Let's go ahead and try to resuscitate them with the blood.
That necessity is driving their use of the device.
Yeah.
And early success says, okay, well, if we like, obviously part of that is assessing as you go along, like, are we still seeing what we expect to see in successes, right? And if you don't, okay, let's not just charge forward with it. But if it has early success, if it makes sense, of course, let's not hold it from everybody. It's kind of like that emergency use authorization type stuff where it's like, oh, well, we have to like, why would we keep this from anybody? Because it's important now.
Yeah. Well, and we haven't gone for any kind of an emergency use authorization, but I'll tell you, generally it's off-label use. So if somebody goes, hey, that thing works this way, then people start using it differently. So like, for instance, another just straight hemorrhage control reason for the device being used is traumatic cardiac arrest, which was sort of a surprising one to me, because I really wasn't thinking about this. But when the U.S. Air Force did their study looking at its equivalency with Reboa, the researchers did 2 projects sort of at the same time. The second project that they did was using pigs. They basically bled pigs out to asystole. So traumatic cardiac arrest, in some places in the world, it's called hemorrhagic cardiac arrest. But the idea is your heart's not stopping because of an electrical problem. Okay, it's not stopping because there's a clogged up artery somewhere and you had a massive heart attack. It's stopping because you've had a trauma, you've bled, and there's literally no oxygenated blood left to circulate around, and the heart just stops because there's no blood left.
Right.
And so when I was growing up in emergency medicine, we would tell paramedics, never work a code on a car accident. Those people are dead. You can't get them back.
Sure.
And it's not survivable. And so now there are some that do survive, but you have to do a lot, and you generally have to be able to give blood. So the Air Force's study with these pigs, they bled them to asystole for 3 minutes. So there's a period of time where they're sort of what we would call peri-arrest. They're starting to get real agonal. It's not really beating much, and then they finally flatline, and that's when they started the timer. 3 full minutes, so no blood flow through the whole body anywhere. Then they applied the device, they gave a unit of blood, and they did CPR. So the caveat to traumatic cardiac arrest generally is you have to be able to transfuse them.
Right.
But they had an 83% return of spontaneous circulation rate.
Wow.
Which was sort of mind-blowing for me. Like 83%? Like, well, if you can give blood, then CPR and your device seem to be an effective adjunct. So the Australians decided to put it to the test. They published a paper in 2019 where they were doing scene flights. This was an air ambulance service, 44 different patients that had traumatic cardiac arrest. And the downside with their study is that their mean asystolic time was like 16 minutes. Okay, so no blood flow to the brain for 16 minutes. I'm sorry, your brain's just not going to recover for that. And they had about a 23% return of spontaneous circulation rate by applying the device, giving blood, doing CPR. But again, because of the length of time, none of their patients left the hospital. So some docs in San Antonio with the San Antonio Fire Department said, hey, we can get there a lot faster than 16 minutes. So they started enrolling patients, and they presented at EMS World 2 years ago an interim on their project. They had 13 patients. Their mean asystolic time was about 5 minutes. Few of their patients had overwhelming CNS injuries, but they were able to get return of spontaneous circulation on some of them. But they basically had a 22% that they were able to get return of spontaneous circulation. Theirs walked out of the hospital alive. Now that is huge. Wait a minute, you just improved outcomes from almost 0 to 22%. So the Ukrainians, there's some Ukrainian doctors that saw these studies. They'd already been using the device from a hemorrhage control standpoint. They had quite a lot of use of the device. There's been a couple hundred lives saved, I think, in Ukraine at this point. But so they were comfortable with the device. It was in Ukraine, and they were using it both at their at the front. They were using it in transport to the first point of surgical stabilization, and then they were also using it at the surgical stabilization point, the forward surgical team point. And this one physician, Dmitry Andrushuk, said, I think this might work with this cardiac arrest. So if you take a patient to the hospital, let's say they lost vital signs when they arrive or within 5 minutes of arrival, then very often we do clamshell open the chest, cross clamp the aorta, fix a hole if there's one up above. And if they survive, then they're dealt with all of the trauma we just caused.
Yeah.
They got to deal with all of that. So they were having these patients come in with horrible pelvic and lower extremity injuries, just massive injuries. And so they had 6 patients in fighting in Bakhmut region during 2022 that came into the surgical stabilization site or en route lost vital signs. And if they did, they applied the device, gave blood, and did CPR. And they had 100% return of spontaneous circulation. And on those that they were able to resuscitate, once they resuscitated them, they did not require vasopressors to maintain blood pressure after that point.
Really?
One of the patients died at the forward surgical stabilization site because all the ambulances had been destroyed by the Russians, so they couldn't evacuate the guy. Another one died 10 days later from something, multi-system organ failure. I think infection was the reason for his death. The other 4, they followed out to 18 months, all alive and neurologically intact. So the idea, it really has to do with timing. So the Air Force had 3 minutes of asystole. The Australians had 16 minutes. The San Antonio Fire Department had 5 minutes. And the Ukrainians were saying, no, we're doing it at the moment they get asystolic. Like we maybe 1 minute, 1 or 2 minutes. And they left the device on up to 120 minutes on these patients, and they did quite well. They were able to follow them out an extended amount of time. From trauma standpoint, we like to know what is the 90-day mortality.
Mm-hmm.
You know, if you apply something, if you do something that works, what happens to the patient at 90 days? Are they still alive? Did they suffer? Did you rescue them for 10 minutes and then they went on to die? You know, so the idea of being able to follow people out for long periods of time is very, very helpful from the safety standpoint.
That's awesome. That was actually going to be one of my questions for you. You know, it sounds like we're seeing different organizations making this a main line for those lower pelvic injuries and you know, potential aortic injuries. Just that's their go-to. Like we were talking about with tourniquets, limb tourniquets earlier, that it's our first line kind of intervention. This is becoming a first line intervention in those instances. And especially I'm very surprised to hear about the cardiac arrest, traumatic arrest aspect of
Isn't that awesome?
That's very cool.
That was what really, like, hearing you talk about that at the expo, I was like, wow. Like, because even from my perspective, being very new to this, hearing these kind of two things coming together, the idea of the blood, like, you know, blood product in EMS, you know, like the making that more prolific, and then hearing about other types of interventions that can then combine the benefits of these things together. Mm-hmm. It's like, wow. Like the possibilities start, you know, coming up as like, there's so many more lives that can be effective and saved by innovation and new things coming to the market. Let me ask you a question. You know, hearing all this success, the potential of where this is going, where do you see this fitting into the EMS space, like protocols wise, or, you know, how do you see it being used in the next 5 years, 10 years?
Yeah, well, it's very interesting. There are a number of things that have come about. Like, for instance, so we talked about traumatic cardiac arrest. The Air Force, a medical cardiac arrest, a VFib, you know, look, and the American Heart Association researcher that's also done some initial look at this. So the American Heart Association study looked at coronary perfusion pressures and found that when you apply the device and you're doing CPR, the coronary perfusion pressures. Okay, so the whole purpose of CPR is to circulate blood around the body,
right?
Get the oxygenated blood to the brain, other organs, but primarily to the heart.
I thought it was to get CPR, like a workout,
to restart the heart.
You know.
Yeah, well, the idea if you can increase the pressure in the arteries in the heart, mm-hmm. that's what coronary perfusion pressure is. Mm-hmm. So you get more of that oxygenated blood delivering oxygen to the heart muscle that needs it, so it can start going again on its own without you having to do CPR. And so if applying the device doubles the coronary perfusion pressure, that might say, well, we might even have a role within medical cardiac arrest.
Interesting.
A researcher out of the University of Mississippi, I talked to them. They have some early modeling data looking at what are the concentrations of cardioeffective medication. So if you cross clamp the body at the belly button then if you give somebody epinephrine, you're not now waiting for that to go all the way down to the pinky toe before it gets to concentrations in the heart. So will cardioeffective medications get to higher concentrations faster? And may that change our look at the way that we use medications in medical cardiac arrest? So medical cardiac arrest, we talked a little bit about blood and the ability to enhance that capability as well. But then another sort of something that wasn't very common sense was, and it was actually a safety question that my co-inventor and I had for a while, was, what if you have a hole that's actually above the site of your application? So, for instance, when the Air Force did this study and looking at the equivalency between RIBOA, one of the reasons that RIBOA is used is in our device, when you apply it, you get a bump in mean arterial pressure. So your mean arterial pressure jumps up by like 15 points. So you get better perfusion just by applying the device. So you take somebody who's in shock, you can actually get them out of shock simply by applying the device. It just allows the pressure being generated from the squeeze of the heart is now not being distributed throughout the entire body, again, down to the toes. It's now stopping at the waist, and all of that pressure is being applied up here. So you get an increase in mean arterial pressure. Well, the thought was, if you have a hole above that site, are you going to make bleeding from that hole worse? And so there's actually a great study by a researcher named Jacob Glazer, who's out of Madigan Army Medical Center near Seattle. When RIBOA was initially going to be used by the military, they thought about this problem too and said, hey, listen, if you have a hole in your chest somewhere, don't do RIBOA. You're just going to make that person die quicker. And he's like, I don't know that that's right. And so he actually did a study looking at 3 different injuries in the chest, one to the lung, parenchyma, one to the very large vein in the chest, the azygos vein that allows blood flow to come back into the heart, and then an artery, the subclavian artery in the chest. So if you have those 3 injuries, do you have worse bleeding from those injuries if you do RIBOA? And is there a change in short-term survival? And he found that no, there's no change in either short-term bleeding or short-term survival. And so he argued you shouldn't have this as a contraindication for using RIBOA. Now, he was looking at what's called zone 1 RIBOA. So zone 1 is right in the first part of the aorta, up right after it leaves the heart. The mean arterial pressure increases in zone 1 are huge compared to zone 3. So when I talked to Dr. Glazer, I said, do you see any problem with a hole above with a zone 3 application? He's like, no, not at all. And the researchers in the Air Force were like, we're not even going to study that. We already got that answer. It doesn't make it worse.
Right.
Well, we still had it on our mind. And so some British surgeons in Sussex near Birmingham, England, did a study looking at application of our device at the abdomen, just where we currently do it, where we got safety data going back 13 years. If we put it right there, we believe that it increases inter-abdominal compartment pressures. Okay, so that space between the diaphragm and where you're putting it, the pressures around those organs are going to increase. Does that increase treat a hole above? So if somebody has shot in the liver, or they have a fractured spleen or a lacerated liver from an automobile accident, a paramedic has nothing they can do other than grab them and run like they stole them. Get them to the surgeon.
Run like they stole them. I'm going to use that.
Yeah. But maybe that's not true. Maybe you actually have a treatment option. And so they actually found that, yes, they're applying the device at the abdominal site increases inter-abdominal compartment pressures by 40 millimeters of mercury pressure. So if mean arterial pressure, trying to push blood out the hole, increases by 15 millimeters of mercury pressure, but the pressure trying to keep the blood in the vessel is 40 millimeters of mercury pressure, the bleeding does not come out the hole. It stays in the vessel. They presented that this last year at a Special Operations Medical Association meeting, and it got everybody thinking. In fact, now there's a study, again, at Madigan Army Medical Center looking at this specifically. The British researchers went on to do ultrasounds on themselves, researchers, human volunteers, where they applied the device at the abdomen, put up the pressure, and actually looked at the blood flow through several of the arteries in the upper abdomen and found like, yeah, actually you can actually measure the decrease in the flow of blood in those vessels just by applying it at the abdomen side. So we call that non-compressible torso hemorrhage. So you just can't put your hand over something, but if you could actually apply this device, then it might give a medic an opportunity to actually impact somebody who's been injured there. I had a patient about a month ago who had been shot in the upper abdomen, and we put this device on, and it was it to be honest with you, it saved his life. Every time I tried to take the pressure down, so we actually had the pressure up for quite some time. In fact, actually over 2 hours. That's not ideal. It's not what we want. But every time I tried to take the pressure down, the guy's blood pressure just tanked. We were giving the guy blood. I'm trying to get him to our trauma center. I don't work in a level 1 trauma center. There were delay after delay trying to get him up to this trauma center. And we finally were able to get him up there. He did have some ischemic complications from having it on for over 2 hours, but he lived. And the idea that he would not have made it to the trauma center had the device not been put on him. He would have just simply died. And so the non-compressible torso hemorrhage, but then there are also some other very exciting things about where could it fit into the paramedic space. So one of the more sort of exciting ones right now is postpartum hemorrhage.
I saw a success story on the website about a woman who was saved, right, with postpartum hemorrhage. Yeah.
I had the opportunity of interviewing a Ukrainian OBGYN physician and one of her patients. She's actually saved. I think at this point we're up to, they have a study that she had. So in Ukraine, she works in a regular hospital in the interior of Ukraine. So she's not on the battlefield, but they are operating in what we would call a resource limited environment. Sure. Now they have access to pretty much everything except anesthesiologists. Most of their anesthesiologists are at the front line. So they are left at times with one anesthesiologist covering more than one hospital. And so if they need to go to the operating room emergently, they have to sometimes wait for the anesthesiologist to get there. So
take a cab across town.
Yeah, well, it's a crazy situation because they are not a third world country by any stretch of the imagination. Right. They have very first world capabilities. In the US or in any hospital system in the first world, if a woman delivers a baby and her uterus does not begin to contract, that uterus, which is a muscle, sort of is just floppy or flaccid. It's called an atonic uterus. It just has no tone, no tonality, no muscle tone to it. And so when that happens, the uterus bleeds because the connection between the woman's body and the baby is through this placenta. And when the placenta comes out, it's just a bunch of open blood vessels.
Right.
And they can bleed out in very rapid 2-4 minutes tops.
Yeah.
And so if this happens in a hospital, we give some medicine, oxytocin, Pitocin. We do fundal massage. So one hand on the inside, one on the outside, and we're trying to massage the uterus, say, come on, contract down. There's something called a Valkyrie balloon where OBGYN can put in a balloon, inflate it in the uterus. And these women got all of these interventions, but yet they were still bleeding. And that's the decision point at which time the OBGYN says, we got to go to the operating room. And so they call for the anesthesiologist and they were needing to wait. Well, one of her partners had been exposed to the device through his work in the front lines and said, y'all don't think about using this. There had actually been a couple of articles written by OBGYN saying, look, this looks like something we could use for postpartum hemorrhage. The World Health Organization guidelines for what do you do in this situation is external aortic compression. And so even most OBGYNs will say, I just use my fist. And we push down into the abdomen just to try to stop the blood flow to the aorta. In the military, we would say we use a knee, but they don't get up on the operating table and put a knee on. They just try to, put their hand on. But so they put the device on, inflated it to the full 250 millimeters mercury pressure. And she started with 4 women. She had a small safety study. This would make sure that we're not going to hurt anybody. Well, all 4 women survived. In fact, one didn't even require surgery. The pressure alone allowed the uterus to begin to contract down. So it opened up a larger 20 patient study. And the time I did my interview with her, she had already had another 5 patients that she had saved with the device. So they were up to 9. She had presented the data at a OBGYN conference in Spain this year, and will be coming to the U.S. to present it at the American College of Obstetrics and Gynecology this next year. And it's really opened the door. So a paramedic who deals with a precipitous delivery, it happens, and it's a scary thing. It's a scary thing as an ER doctor. I do precipitous deliveries, but I've been blessed to work in a hospital that has had OBGYN coverage, so they run down or come there quickly. Until about 2 years ago, when our hospital system decided to let all the OBGYNs go. And so we don't have an OBGYN department anymore. So if a pregnant woman comes and I deliver a baby, we get an ambulance. And hey, we got to get that baby to the hospital with the OBGYNs and the NICU if they need it. So it becomes a bit of an emergency because I'm not trained in doing the Valkyrie. I can do the oxytocin, fundal massage. What is a paramedic or an ER doctor that doesn't work in a hospital that has an OBGYN do? So their study is meant to look at this kind of a solution. And there are a lot of places where there is a limited accessibility to OBGYN doctors.
Right.
And so midwives helping deliver a child can do a lot of things, including the Valkyrie balloons. But what happens when that doesn't work? And so postpartum hemorrhage is another one of those areas.
That's amazing. I mean, absolutely fascinating. The use of the AAJT-S in postpartum, right? Like saving lives. Like, I mean, did you imagine that was going to be part of the story when you first developed?
Oh
this?
yeah, no way, man.
Yeah.
No way. I mean, I think the focus initially was so focused on Bob Horgan's injury that the idea was we just need to try to find a way to prevent that guy from dying again, from somebody that had a similar injury from dying again. And so as we've gone through, it's fact, I mean, there's over like 70 peer-reviewed papers on the device. I think I account for maybe 3 in their case reports and of my use on them. But it's interesting because there's 4 junctional tourniquets out there, and 2 of them really aren't utilized by the military anymore, the combat ready clamp and the junctional extremity trauma tool, the JET. But one of the special operations community uses ours solely, really. I mean, there's one other one that they will occasionally have with them, but ours ended up being not only the only one to actually save life in upper junctional. So the idea of an axilla injury is another one, very, very hard to treat. It's not really common. It's probably the rarer of the junctional type injuries. So we have the capability of treating it. But when we are moving somebody, we're bending, we're hoisting, we're dragging.
Yep.
And so the idea of being able to have hemorrhage control that isn't lost when you're moving somebody is a big deal.
Right. Yeah.
And it was the only device that didn't lose hemorrhage control when you move somebody. So all of the other devices, there was a study in 2019 looking at the other devices at what their what happened when you move somebody, had a failure rate somewhere between 26 and 45% of the time. Now, basically what that means is what we all do, reevaluate. So you just have to stop, reevaluate, reposition if you move the patient again or you had some other movement. But
just like any tourniquet.
Yeah, just like any tourniquet. But ours, it's you put it on, it's on, and you can hoist, drag, bend, throw them if you needed to. You're not going to lose that hemorrhage control from where the device is placed. Part of that's because of the large surface area. So all the other devices were sort of point compression, and ours is an area or regional compression device. And then there's the way that it's attached around the body. I mean, it's snug on you, really tight. It stays there. It just doesn't move. So the movement thing became sort of probably the aspect that won over most of the guys in the special operations community. Plus the idea that it's one device that just does a bunch of different things. So if you have something in your toolbox that you can utilize for a bunch of different things, then you're carrying more capabilities than the number of devices that you're carrying.
Yeah, multitasking is huge.
Yeah.
Like
Oh,
the fact that it is it 5 like axillary, inguinal, pelvic,
Yeah, there's
pelvic
4
binder
placement
Yeah.
parts. Yeah. 4, you can do axillary, inguinal. The pelvic is just sort of around the trochanters without inflating, and then the abdominal site application. But then it's the indications, or like what can you treat with all of that? And
Right.
then you just start going through all of these different these different areas. My CEO Scott Dodson loves calling it the Swiss Army knife,
Yeah.
of tools. The marketing girls have done something with several of the videos where the AAJT is rotated and it sort of turns into the Swiss Army knife looking, graphic. And it's nice, but it's interesting because it's also, if you think about what we carry in the pre-hospital space, everybody's limited in an amount of size.
Yeah.
Mhm.
You
so-
can only fit so much
Yeah,
in the
weight and cube
Yeah.
matter. And it's not a sterile device. It's so it comes in a package, but it doesn't have to remain sterile. It doesn't have to remain in a package. In fact, one of the special operations units that uses it takes it out of the package. They actually refold it to make it longer but thinner.
Yeah.
And then the backpack that this specific unit uses, it's called the M9. It has this sleeve in the back that
Mhm.
sometimes you might think about putting like a hydration bladder or something like that in there, but
yeah.
you can slip that down in the sleeve, and so it sits there. We have a version that's in development for the special operations community that is that exact same size that you've got right there. There's a few things that are different. The wings are cut down just a little bit, but there's a cut made in the base plate and it folds over, and so the cube goes down tremendously in the pack space.
Okay.
So you could actually probably put it in a cargo pocket of your pants if you want to. Not that anybody would really fit
Yeah,
it there,
I mean-
but it does make it smaller and more easily placed into a pack. But what we found is when guys take the device out and they do training, so they do live tissue training. So when
Yep.
we work on anesthetized animals,
Yep.
to learn our trade, to make sure that we can do it on a live human when we need to, they go, oh my gosh, the capability of completely stopping bleeding in all of these different cases leads to saying, well, actually, I need to find out where I need to carry this thing because I'm going to carry it. I'm not going to not have this thing. Some of them carry it on their primary pack. It's also put with litter packs. So we have these bags these foldable stretchers, these litters come in and, that we carry them in. So they'll attach it that it'll be in our vehicle kits, it'll be in a door drop kit. So sometimes when they're going on an operation, if they reach a place that they're about to enter, they'll have some things medically that they have on them.
Right.
They'll have another bag that sometimes they'll just drop at the door or at a casualty collection point.
Yeah, it becomes like a secondary item where it's like, like I'm not going to carry it on me at all times, but we have
for paramedic standpoint, you got the go bags and everybody's carrying something different. But if you are responding to a trauma, then they grab the go bag that has this on it, or they have a pouch. We've had some EMS organizations actually create a little pouch that they can actually strap to just one of the arm straps. So it's attached to the pouch, so the bag. So when they grab the bag, it's coming with them. But it's just carried in a little different location.
Yeah, I would imagine in my services, so I've, again, limited experience. I've only volunteered with 2 services so far, but to me, I would imagine, if we have one of these, it's going to live in one service, there's the car crash bag, right? There's that's our trauma bag. Now it's got extra tourniquets, bandages, pelvic binder. That's where it would probably be. Cause there's only so much that you could fit in the first aid bag at any one time. But, the deployment and the staging of where stuff is sometimes as important as, because if it's somewhere else, if it's locked behind a thing, if you don't know where it is, what's the point, and this, it was one of the things that when I first saw it, I was like, man, that's big. But knowing that okay, there's always ways to solve the challenge. And it's so interesting to hear. Cause when I was, cause I have this one and the plan is to put it in a bag, but knowing like, oh yeah, like other people are figuring out the same things I did, where it's like, oh, that's going to go flat and it's going to slide in, into the long part of the bag, or, all those types of things.
Yeah. Yeah. There's a lot of different sort of solutions for that, but it really has to do with if it's something that you feel like you need. Like we were talking a little bit earlier about the ways to improvise a junctional capability, with an Algene or such. There's not really a way to improvise the abdominal or truncal capability. You can't tighten a belt with an Algene under it tight enough to stop the blood flow to the aorta.
Right.
Yeah. It just doesn't work. So, and most paramedics don't really think about that being a capability that they need. So, they got a pelvic binder or a bed sheet, which works as a pelvic binder.
That's what they taught us.
But they'll put one of those on. That's what I'm caring for pelvic bleeding. But are you really treating the pelvic bleeding? And did you know that you actually could treat the pelvic bleeding? Right. And once they realize, I can actually deliver a patient alive that's not in shock, and give them a better chance of living, then the capabilities of the device, that the traumatic cardiac arrest, the hemorrhage control, postpartum hemorrhage, possibly medical cardiac arrest, more to follow on that one.
Okay.
And then and there are all these questions, the blood, being able to be an adjunct to delivering blood. All of these things, I think it just becomes, wow, why would we not have this tool available if we needed it?
Question for you, and I know this might be a little bit out of left field, but I know it's one of the things that I just learned about, or I'm like, man, I hope I don't encounter many of those in terms of like abdominal aortic aneurysms. Like, is this potentially something that could work in that space, or is that contraindicated?
It's a very interesting question. Well, so there's two contraindications to the device: pregnancy and known AAA. You might ask, why are those the contraindications? Well, to be honest with you, when we came up with the first regulatory submission in 2011, I just threw them in because it was a common sense thing. I was like, well, I don't think I would want this thing put around a pregnant woman that could hurt the baby.
Right.
And then what if the idea with a abdominal aortic aneurysm or a dissection, let's say, the problem becomes in what we call shear force. So if you actually increase pressure inside the vessel, then you potentially could make something worse. So the reason those are sort of relative contraindications, though, is if they're going to bleed out from dying, then are either of them real contraindications? So the idea being, if mommy's going to bleed from dying, baby's going to die too.
Right.
And if you have an abdominal aortic aneurysm that busted, well, who's to say now with the research that the British did, that this actually may not be this could potentially be a treatment for that, to get them to the hospital in time for the surgeons to go in and actually open them up and try to save them.
Right.
So, more to follow, I guess, is what I
okay. Yeah,
that.
Sure.
But in my mind, we've got enough in the database to know if we're increasing intra-abdominal and intrapelvic pressures, then we may actually have a treatment for problems like that.
That is so fascinating to me. And the thing that I love about medicine in general is that it's always evolving.
Right.
Right. And through all different types of stimulus, like we talked about it before, there's like sometimes the stimulus is things that are the worst parts of humanity, like war and conflict. And sometimes it's just pure thought and innovation that just comes out of nowhere. It's like, poof. Oh, well, maybe if we try this, and like all of that comes together and we get to try it and experiment and, go through the process of figuring out if that works for the thing that we've identified as being the problem. And
well, I'll give you an example. Like, it's what's really fun to me is, like, as we get these research things back, we get questions from people that I never thought would be interested in the device. So we got a call from a GI physician, gastroenterologist. Okay, so the guy that's going to do your colonoscopy and your upper endoscopy, looking for an ulcer. And his thing is, would this work with GI bleeding? And we're like, what do you mean? He's like, well, I mean, this increases intra-abdominal compartment pressure. And if somebody had an ulcer bleeding through their stomach and they're bleeding out, could you put this on them? Would it stop that kind of bleeding? And we think it probably would. So well, what about these kind of things? Like, so if it stops bleeding, this non-compressible torso hemorrhage problem. So if somebody has an injury to their liver or an artery going to their bowel,
Right.
those are major bleeding. The GI bleeding often is not from larger blood vessels, but it's often from blood vessels that can't be fixed from an external pressure perspective. You guys should either have to do endoscopy or do a surgery or do an interventional radiology procedure to try to stop that kind of bleeding. So diverticular bleeding is another one where somebody has a diverticuli, and instead of having diverticulitis, where they just have inflammation or infection of that diverticuli pouch in their colon, they've got bleeding. Well, that's not something the GI doctor can actually fix. Most of those have to be fixed by an interventional radiologist. And they go in, do a little procedure, they find the bleeding vessel, and then they stop the blood flow through that bleeding vessel. Well, those guys are few and far between. So like in Birmingham region, I've got 14 hospitals. I only have one of the 14 that has an interventional radiologist that can do that procedure on nights, weekends, or holidays. So then what do the other 13 hospitals do? Well, we try to send them to that one hospital that's available, and that hospital sometimes gets overwhelmed. So
could imagine
if
why.
you had something, well, and then could they bleed too much before they reach there? So
right.
And if you're talking about the idea of we can treat hemorrhagic shock, well, could you impact other forms of shock? And so we had an infectious disease doctor reach out about septic shock. I'm like, could this treat septic shock? Well, it doesn't treat the problem that septic shock is caused by.
Right.
But often in the ER, I'm not treating the problem. I mean, I'm giving them antibiotics.
Right.
But they're in septic shock because their organs are beginning to fail. And
their blood pressure's dropping.
Yes, their blood pressure's dropping. Their heart's not pumping blood strongly. And so we're giving them a lot of medicines, vasopressors to try to increase their blood pressure. Well, what if, as an interim, until I could stabilize them from a chemical and standpoint and get fluids into their body, oftentimes they require a lot of blood fluid. What if we put the device on? Could you stabilize somebody, or would it be an adjunct to stability? So, and then got a call from neurosurgeons talking about neurogenic shock. So traumatic brain injury has a very similar statistic in pre-hospital hypotension in traumatic brain injury, and their increase in mortality as the pelvic fractures do. And so, hey, could we prevent and also, if the brain is injured, it doesn't do well with low blood pressures.
Right.
So we don't want it dropping down too low. We actually don't want it too high either. And so we don't know what that answer is. When you apply it, does it increase it'll increase pressures. So they're really wanting to prevent the hemodynamic instability of low blood pressure with somebody that's got a brain injury. And this could actually potentially help with that. So that's the kind of thing that's become quite fun. You were asking, hey, you've invented anything else? Well, most of my effort has been, gosh, this is interesting. Who wants to do research in this?
Yeah.
And then we find docs that are interested in doing research. So I think right now we're tracking 22 different projects, research projects that are being conducted. And they're all over the globe. In Cali, Colombia, with trauma patients. In Austria, they're doing, they just published they just finished doing a 10-patient safety trial, and they're about to launch a 14-center, multi-center trial in Austria using the device on traumatic injuries in the civilian space. In England, in March, they're starting what's called the Occluder trial in London and in East England, looking at the device's use in the pre-hospital space. And so we've got all of these different things. There's a bunch of them in the U.S. being done right now. In Texas and up in New Jersey and in Florida and in Virginia. So what's so fun to us is learning what people are interested in looking at, and then they're finding these new capabilities. I used to be nervous when I heard people were doing research about the device. I'm like,
it's like, I hope they don't poke holes in it.
Bad?
Yeah.
So when we first put these on animals, we thought we would kill all the pigs. No way you could occlude all the blood flow to the aorta and anybody lives. And then we're like, oh, they actually lived and it worked. And so as we go through the process now, I'm no longer worried about, we understand the safety of the device quite well after all of these years. Now it's finding out what are the additional capabilities. What else can you do with this? It just so fundamentally changes human physiology that we don't know all of the potential benefits.
Right. Which I think is the fun part of the Compression Works story, of the AAJT-S story, is that it's like, it's not defined yet. Like it came from a very kind of pointed, simple place, but it's like, it's expanding out, and the potential is so interesting, because at its core, it's, not only is it, it stops blood flow to the bottom half of the body, but like, from my layman's approach to it, it's like, oh, but it's now also a mechanical device that helps with blood pressure, right? Like, you're seeing that benefit in all these other types of conditions. And it's like, oh, well, I know that low blood pressure is a bad thing in a lot of different places. So seeing how that play, like, oh, well, the possibilities start popping up, and seeing how that story can connect. And like, I know how slow some things are to adopt into the emergency medicine space. Like, it, tourniquets took forever to become like the first line treatment. Right. So it's interesting to see that hurdle, and like that, how you have that kind of, thing to address, but the hearing all of successes and the ways that it can be used is so fascinating.
Like the EMS organization, most EMS organization, when you're asking about how does this fit into what they use and how they use it, that means it's got to fit into a protocol.
Yeah.
So you look at what protocols exist. And so, some EMS organizations will bring it in under, they may have a massive hemorrhage protocol. So they have a list of things that they do, from pressure to extremity tourniquets to hemostatic agents, and then ours fits in there. And they might have a pelvic bleeding protocol, and it fits in there. A lot of the use in Texas has been entry into the service in their traumatic cardiac arrest protocol, and then they'll come back to us at some point and go, okay, what else is it doing? Where else can we put this in protocol? So it's really sort of fun, and to see, would you share your protocol? Let us see how you're fitting that in, because we've got this this database, if you will, of the way that different services put it in protocol. So when an EMS organization, it's like with the blood, how are you guys using this with blood? This is how we use it. We arrive on scene when they meet the criteria for blood. We actually have one paramedic get the blood set, and the other one's putting this on, and then they go ahead and do the blood. So it's neat to see how it fits into the protocols, and then we have that information available. So when a medical director comes and says, how do I fit this into our current flow of patient care, we can say, well, we can give you examples of how others have done this. We have examples from National Association of EMS Providers in a EMSP that has guidance for medical directors. We've got a lot of state medical control documents that now talk about junctional hemorrhage and massive hemorrhage, and we have examples we can give to them. And so, it's been neat to see how it just sort of fits into the current flow of work. And then as paramedics begin to see, oh, I can use it for here. All right, I'm going to try it.
Yeah.
And then they call us saying, hey, man, I think I just had a life saved because of this device. And now we've got these little coins. If you know somebody who saved a life, let us know, because we've got a life saved coin. That
that's awesome.
Basically we love giving to the paramedics.
Yeah.
It's like, hey man, congratulations, you saved that person's life. Thank you for using our device in that process. And we like to recognize folks whenever they do that.
That's so cool. I mean, like, it must be so rewarding to hear those firsthand, like, hey, we have a save. Like, I can only imagine the story of, or like, having that feeling of like coming through that process, identifying this problem, right? Like, okay, I think we can find a better solution to go through all the turmoil of developing this thing with the book, and then figuring out how the blood pressure cuff. Okay, now how do we do that in a product? And then like everything from there, through proving it, through getting it into usage, to now get those stories of, oh yeah, this just saved the life of this guy here in Miami, or this woman who is postpartum in Ukraine. Like, that's incredible. Did you, and I can tell from you telling the story that like you're really jazzed about the idea of this thing being kind of adopted and people studying it. Did you ever foresee yourself when you first came into emergency medicine getting so jazzed about the research side of medicine?
Yeah. Oh no, man. I think that I love what I do in emergency medicine. I love our patients. I love being able to give compassion and care and to these people that when they show up at the ER, no one comes to the ER really knowing that morning that they were going to go to the ER. And so they're usually there scared. They're maybe scared about something they're experiencing or something their family's experiencing. I actually love that part of what I do. It's one of the reasons why I continue to do it. I really enjoy it.
Yeah.
But there's something that it's just at a different level when you have that sense that every moment that you spend related to innovation and research along this will lend itself to countless numbers of stories of people potentially being helped from the device. And now, I mean, it's just, yeah, it's so motivating. And that's why I think you saw so much energy at the booth. You know, I've got this incredible team. Our CEO, Scott, has experience out the ears. He didn't have to do this. He'd actually sort of retired. And then he so motivates our team because he's like, of all the things he's done, and he's worked with Boston Scientific, with very large companies and very excitable, exciting new startup type companies. But he's like, of everything he's done, he goes, there's just something about this device where you have that interaction with people who are actually saving lives. It's just making that kind of an impact. So all of our folks are like that. It's just fun to be around them. They're jazzed about it. I'm jazzed about it. I want to be the chief mad scientist. That's what I love doing. I love the development.
I love it, man. I love it. I knew it from the minute I met you guys. I'm like, there's something special about this story. And admittedly, I'm sure if anybody's kind of gotten through this part of the podcast, this part of the interview, they're like, wow, this is kind of different than everything else that these guys have been doing so far. Because we're working at the entry level, right? We go through the subject matter of EMT textbook, right?
Yeah.
But I think the thing that we've identified that we love about this story on the EMS side is that there's so many different aspects of it, and being able to connect and help tell the story of like the potential of science and medicine, and also the very human story of, identifying a problem, creating a solution, making it work. It's like, there's something so cool about that and intrinsically linked to the idea of medicine, right?
Yeah. Well, I'll tell you that one of the neat things about sort of that EMT basic level and above. So one of the nice things about the device is you don't actually have to know medical anatomy.
Exactly. Yeah.
Right.
If you can follow a pictogram, you can do it correctly.
Red to red.
The idea of area compression means you don't have to be point specific. So the other junctional tourniquets, you really do need to know where the anatomy lies to be able to put them on correctly. But the former head of the joint trauma system, which is sort of the military's overall doctrine person. So the idea that the military tries to decide what is the best approach to different types of problems. So joint trauma system, big deal. But she used to refer to it as the no-brainer device. So, you don't have to know the medical anatomy. You put it on, and then you don't have to worry about it working. It's on, it's working, and it's done. And so one of the reasons we had a lot of, in fact, a lot of communities started using it in the tactical law enforcement standpoint because the law enforcement officers could put it on.
Yeah.
You don't have to have advanced medical knowledge, and just 5 steps, no matter where it's at, and it's on and working.
Yeah. I think it's great. This is such a cool device. And I think it's got so much potential to it. I do have a question for you. And this is really to anybody out there who do you have any advice or, kind of watch outs for people that are looking to make that leap, that are looking to either get into medicine or identifying problems and creating solutions for them?
Yeah, well, I mean, do it. I mean, keep a
Just do
notebook.
it.
Well, no, so like like, okay, so I've got two grown children and I've got a 13-year-old, and I've encouraged all of them throughout different parts of their life to keep a notebook. If you come up with an idea, write it down. Even if it sounds like a crazy idea, write it down. Now with your phones, you can, have a note app that just says ideas
Yep.
or inventions. If you think it's crazy, put it down. Then you can always search to see if somebody's done it.
Yep.
But I think that don't let I don't know how to do that prevent you from trying to do it. And so if you I think that the provisional patent that I put on the first device I did using LegalZoom, the online legal service that allows you to do a provisional patent for a few $100s, and
Yeah.
that gives you 1 year. The provisional patent gives you 1 year protection. No one can steal your idea, but it gives you 1 year to decide whether or not you want to spend the money to actually apply for a full patent. I would recommend that if you apply for a full patent, get somebody's help. LegalZoom has that capability. They can have an intellectual property attorney help you write a full application. You can do it on your own, but they can actually help with your chances of success and the way that you write it to help secure your idea.
Right.
So somebody can't come and just change one little thing and then say, oh, I've got an idea that's different, but it actually is the same idea. But so you get 1 year to sort of play around with the idea. Then don't sit on your hands.
Yeah.
So if you come up with the idea, you do it. If you get up the gumption to do a provisional patent, then try to do a prototype that will work. And you can do that prototype any way where you've heard some of my crazy stories. And then if you decide that it works, then come up with a plan. And that's not that difficult. Get on LinkedIn, find out people who have helped other companies get to that point, and find out what's involved. You can go with an idea to a medical device distributor or manufacturer and just try to get royalties off your idea. For an inventor, the average royalty rate is probably 4%. So that's not much. It's very little. I would actually encourage pretty much everybody to do it yourself. So the idea of doing it yourself, it depends on how much you want to do. Right. So if you have an idea and you bring it to somebody and they say, okay, we'll do everything. We'll do the prototyping. We'll secure the intellectual property. We'll by doing the full patent application, then we'll make it, we'll sell it, we'll distribute it, we'll market it. You're going to get up 4%. If you say, well, I'm actually just going to develop out the prototypes, come up with the final design, get the regulatory approval and the intellectual property, then you actually own it.
Right.
And then you're just contract manufacturing, getting them to make it. You get somebody else to distribute it. Like there are ways around all of these things. Don't let the next problem stop you from answering the first one.
Sure.
So you just start. If you just start. So this has been a crazy ride. I didn't have any of this training. I know. I mean, I'm a doctor. I mean, God didn't make me a businessman. All right. He made me a doctor. I have benefited from having people. I would just simply ask the questions. So I had a doctor friend who's my current co-inventor, and he was already further in life than I am, and he's retired now. But I asked him, well, can you help me understand how to do this? How do you do the patent? How do you make a prototype? He's like, I said, you could have part of the company. And he's like, I don't have time really. And I was like, will you just walk me through it? And I gave him some ownership in the company, and he's truly my partner. In fact, actually we listed his name first if you get a patent, whoever's listed, they're all 100% owners of the patent. So it doesn't really matter what order your name is. If you look on this last patent that we did, Richard Schwartz is the first name. And I did that on purpose because if not for him, none of this happens.
Right.
Okay. So we're co-inventors, but without him, that doesn't happen. So, I mean, I love him to death. He's a mentor, a friend, a close friend, somebody I would trust with my own family as far as how he knows how to care for people. And he's a very, very good thinker. But having somebody you can bounce ideas off, but just don't let the next problem stop you from answering the first problem.
That's awesome. I mean, that's great life advice right there. No matter what your endeavors are,
absolutely,
just keep going. Like, just figure out what comes next and keep going after it. Like, there's so much heart in this story, and I think it's so great.
Before we wrap up, Dr. John, we have a segment that we do every week on the podcast. And it is a student tip of the week for brand new EMS students, maybe brand new providers. What is one piece of advice you would give an EMS student or EMT student as they start their journey, as they're new in their journey in emergency medicine?
Oh gosh, don't stop. Don't give up. Don't give up.
Okay.
Well, and I'll be honest with you. So my background, I was an electrical engineer.
Really?
Yeah, it doesn't make any sense. But I ultimately decided that instead of working for the power company, I wanted to try this medicine thing. I had great grades to get an engineering job, not to get into medical school. It took me like 3 years to get into medical school. Actually failed the very first time I tried to take the U.S. Medical licensing exam. That's in your second year of medical school. I had to retake it. But I had been told, hey, you're not going to get into medical school. And it did take me 3 years. I was told you'll never get into emergency medicine, because it was very competitive at the time. And I ended up getting an opportunity to go to my first choice training location. It just all along the way, I think you have to be good at failing. Don't be fearful of failing. Just get up back on the horse as soon as you can when you do fail. So a lot of my paramedic friends can attest to this, that National Registry is not easy.
No.
And so trying to pass that can be very disheartening, very discouraging, but don't stop. If you get to a point in your education where you're not getting something, don't stop. You can figure it out. Look how many people have figured it out before you. It is something that can be done. So I think my advice to somebody new getting into this area is, if you're passionate about it, do it. And don't, once you become a paramedic, don't stop. Then look for flight certification, look for advanced certifications on top of your paramedic license. And then don't stop. One of our paramedics here in Birmingham that used to always come in, ask me questions about EKGs. He was into it. Hey, tell me. And then he was like, hey, what book do you use in emergency medicine to learn EKGs? And we gave him one, and he was like, okay, I'm going to learn EKG. Well, ends up he's gone to medical school. He's a doctor now.
That's
just
amazing.
Don't stop. If you're driven, if you're passionate about it, keep going. There's no reason just to stop. Even my doctor friends, I think, once they become a physician, then they're like, okay, I'm settling into what I'm doing. I'm
Right.
like, okay, but don't stop. Like, what are you going to do now?
Yeah. What's
How
next?
are you going to solve problems better? How are you going to get more training? Are you going to find out how to do different types of things that you can do to challenge yourself and to help the patients that you're trying to care for?
Sure. That's great. That's great advice. Thank you so much for answering that question, and thank you so much for telling us about your tourniquet. It's amazing.
His invention.
Yeah.
Okay. Allow me to be kind of grim for a second. Everybody dies someday, right? We know that probably more than most in the EMS space, right? On the tombstone, is it doctor, inventor, researcher, dad? Like, what's the thing? Like, you could have one title on the tombstone.
Oh yeah, it's husband and father.
Okay.
That's it, man.
Yeah.
All this other stuff burns away. You if you're blessed to be able to love, and you have a family that cares about you and you care for, that's the legacy, man. Yeah, all this other stuff blows away. It just goes away. If it wasn't me that had invented this, somebody else would have. Innovation will happen. That's the one thing us humans do. We just keep improving things. But you want to be remembered for who you are, and the way that you care for others, the ones that are most important, the one that you have been given that sphere of influence over, those that are in your family and your close friends. So maybe tack on friend at the end of that. But if I was remembered for being a father and a good husband, a good father, and a good friend, I would be satisfied, to be honest with you.
I can't imagine a better way and a better parting thought than that.
Yeah.
On this interview, like, of all the achievement, it's who we are at the end of the day that matters.
That's right.
Yeah. Well, thank you, sir. This
you.
has been an absolutely awesome experience. Everything from meeting you guys and kind of being able to interact with the company, and culminating today in this interview, the connections we make in this space, I think are the things that we should treasure. And like I've been very blessed over the last few months in being able to meet some amazing people in the emergency medicine space, and this is absolutely wonderful.
Oh, you're kind. You're kind. I've enjoyed it. Thank you, guys.
Thank you.
Thank you, Dr. John.
All right, guys, we're going to wrap this thing up. And thank you, Dr. John Croushorn, for joining us on the RideAlong EMT School Podcast. We hope you all enjoyed taking the ride with us, and we'll catch you next time. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in a